Good afternoon, everyone. Myself, Dr. Mohit Bhatia. I am working as Assistant Professor in Department of TB and Respiratory Diseases, Institute of Medical Science, Banaras Hindu University. Today, I am going to talk about community-acquired pneumonia. What is pneumonia? Pneumonia is an abnormal inflammatory condition of the lung. It is often characterized as inflammation of the parenchyma of the lung and abnormal alveolar filling with fluid or exudative materials. So this is the respiratory tract, upper respiratory tract and the lower respiratory tract. Upper and lower respiratory tract divided by the vocal cord and the larynx. So air comes from the upper respiratory tract to the lower respiratory tract. Pneumonia is considered as basically a disease of lower respiratory tract and often regarded as a lower respiratory tract infection. Air comes from the upper respiratory tract to the lower respiratory tract, where in the alveoli there is a respiratory mesothelium and the capillary bed where the process of gaseous exchange takes place. What happens in case of pneumonia? Due to the infection, there is a recruitment of inflammatory cells which lead to the release of various inflammatory cytokines which lead to the inflammation of the wall of the alveoli. So wall of the alveoli become thick, and also there is a deposition of exudative materials which make the process of diffusion of oxygen difficult. So there is an impairment in the process of gaseous exchange. So this is the evolution of the guidelines, different guidelines of the community acquired pneumonia. The first guideline, which were released in the year 2000, the Canadian guidelines. In the year 2001, American Thoracic Society released the guideline for community acquired pneumonia. In year 2003, Infectious Disease Society of America released its guideline. In year 2007, American Thoracic Society and Infectious Disease Society of America jointly released the guideline for the community-acquired pneumonia. Year 2012 was a remarkable year, as in this year, Indian guidelines were released by the joint effort of Indian Chest Society and National College of Chest Physicians. ATS and IDSA released updated guideline in the year 2019. Now come to the epidemiology part. It is the 8th leading cause of death overall in the United States, and infection related death. It is the most common cause of the infection related cause of death, and it is the 8th leading cause of the death in the United States overall. It has the 3.5 million death yearly. Overall attack rate is 12 per 1000 per year, and it affects the extreme of ages. It is more common in the elderly and child group population. So the number of deaths due to the lower respiratory tract infection was 35.1 per lakh population in the year 2008. When we compare this data with the death due to tuberculosis, which was 35.8 per lakh population for the tuberculosis, and when we compare the death due to pneumonia with the overall death due to the infectious and parasitic disease, which is an 194.9 per lakh population. So we found that it is around the death due to pneumonia are around 20% of the mortality due to the infectious disease in India. So it reflects the magnitude of the problem due to pneumonia. The reported incidence rate of CABP in India is 4 million cases per year, which is approximately 23% of the global pneumonia burden and 36% of the regional burden. So we will cover this topic through a case, and our case is a 14-year-old girl with high-grade fever with productive cough and left side chest pain for 5 days, and she has no significant past medical or surgical history. On examination, she was tachypneic, respiratory rate of 35 per minute. Her saturation was 95% on room air. The pulse rate was 110 per minute. Blood pressure was 90 by 60 mmHg. On auscultation, we found bronchial breath sound and coarse crackle in the left mammary, inframammary, and infraaxillary areas. So after seeing this case, we have some question to ponder. Is this a case of pneumonia? If yes, whether it is a community-acquired pneumonia or healthcare-associated pneumonia or hospital-acquired pneumonia. What is the initial clinical classification? What is the risk stratification for this patient? What is the probable etiology of this patient, and what are the initial empirical therapy for this patient? So we will answer this question one by one. So first answer is whether it is a case of pneumonia. So first we have to define what is pneumonia. So what is definition of pneumonia? Community acquired pneumonia can be defined on the basis of clinical basis, on the basis of sign and symptoms suggestive of pneumonia, or on the basis of radiographic findings, on the basis of chest x-rays. Even if the chest x-ray is not available, then we can also define the pneumonia on the basis of clinical sign and symptoms. So what are the symptoms? Symptom of the acute lower respiratory tract illness: cough with or without expectoration, shortness of breath, pruritic chest pain for less than 1 week of the duration, and at least one of the systemic feature: temperature more than 37.7 degrees Celsius, chills and rigors, and patient have a complaint of severe malaise. With the new focal chest sign on examination, like bronchial breath sound, crackles, with no other explanation for the illness like cardiac disease, pulmonary edema, pulmonary infarct. So without these other possible explanation, if the patient having these symptom and signs, so we can define patient as a patient of a community acquired pneumonia. What is definition of pneumonia when the chest x-ray is available? So community acquired pneumonia is defined as symptom and signs as we described in the previous slide, plus radiographic shadow for which there is no other possible explanation is available, like pulmonary edema or pulmonary infarction, and X-ray showing in a lobar or patchy consolidation, loss of normal diaphragmatic, cardiac or mediastinal silhouette, interstitial infiltrate, or bilateral perihilar opacity with no other obvious cause. So if the sign and symptom suggestive of the community acquired pneumonia is present and the X-ray is showing patchy or lobar infiltration, in this case we have the lobar infiltration on the left side. In the X-ray it is affecting left middle zone and the lower zone, and as the cardiac silhouette is maintained in this case, so probable it is involving the left lower lobe. The pneumonia is involving in the left lower lobe. So this patient can be defined as case of pneumonia. Community acquired pneumonia develops in people with the limited or no contact with medical institution or settings. What are the risk factors for pneumonia? Number one, age. As we already discussed, it affects the extreme of ages more. It is more common in the elderly and child group population. Alcoholism causes a decrease in the immunity status of the patient, so make the patient more prone for developing infectious disease. Smoking cause the impaired mucociliary clearance, and which lead to the impaired defense mechanism of the lung, natural defense mechanism of the lung, so which lead to more chance of getting infection through the community. So these smokers are more prone for developing community acquired pneumonia as compared to the normal population. Asthma and COPD, these patients also have decreased mucociliary clearance, and also these patients are on a long-term use of inhaled corticosteroid. So there are many studies which are showing that the patient who are on a long-term use of inhaled corticosteroid, they are more prone for developing infectious disease of lung like pneumonia and tuberculosis. The patient on an immunosuppressive drug for organ transplant or any other reason, so they are also more prone for infectious disease like pneumonia. If the patient is having dementia, they are also more prone for developing pneumonia. So our case is a case of pneumonia, as the patient is having pleuritic chest pain, bronchial breath sound, and patient have no history of hospital contact or hospital stay. So our patient is a case of community acquired pneumonia. So now come to the second question: what is the initial clinical classification and what is the risk stratification of the patient? Why risk stratification is important and the clinical classification is important? Because we have to decide the site of care, whether the patient can be treated on the OPD basis, or patient can be treated on the hospital stay, or the patient require the intensive care unit services. So risk stratification is important. So for the deciding site of care, first we have to look for the thing that is the whether the patient is able to take the oral medications or not. If the patient is not able to take oral medication, such kind of patient should be treated in the inpatient basis, required admission. And second thing is whether the patient is having adequate patient care and support at home, whether the adequate care providers are present and the willingness of the care provider is present or not. So these two things we should consider while deciding a patient on a OPD care. Second is inpatient care. If the severity of illness score like CURB 65 or prognostic score like pneumonia severity index are higher score, patient having higher score, so these patients should be admitted. And above all, the clinical and the professional judgment of the treating clinician should also keep in mind that for the admission of the patient. So what is pneumonia severity index? Pneumonia severity index is a scoring system based on the different parameter, based on the demographic factor like age, sex of the patient, comorbid condition like neoplasia, liver disease, chronic heart failure, physical examination and vital sign like mental confusion, respiratory rate, systolic blood pressure, temperature, heart rate, laboratory and imaging parameters like arterial blood pH, blood urea nitrogen, sodium, glucose, hematocrit, pleural effusion in the X-ray, oxygenation, saturation of the patient. So with all these parameters, we have to calculate the total sum for the patient. And if the total sum of the patient is less than 50, we classified the patient as class 1. If the sum is between 51 to 70, class 2, 71 to 90, class 3, 91 to 130, class 4, more than 130, class 5. As we can see that class 1 and class 2 have low risk of mortality. So these patients can be treated as an outpatient basis. And class 4 and class 5 have high risk of mortality. So these patients should be treated as an inpatient. And class 3 patient has intermediate risk of mortality. So these patients can be treated with outpatient or brief inpatient. What is other scoring system? If the patient is having symptom and signs suggestive of pneumonia with the X-ray finding present or not, or whether X-ray is available or not, as we discussed in the definition slide. If the criteria met for, first we have to look whether the criteria is met for community acquired pneumonia or not. If it is not, then we have to think about the alternate diagnosis. If it is yes, then we have to apply the CURB 65 score and the our clinical judgment. What is CURB 65 score? It is also a scoring system in which 1.4 each, confusion, urea more than 90 mg per dl, respiratory rate 30 per minute, blood pressure, systolic blood pressure less than 90, diastolic blood pressure less than 60, and age more than 65. If the patient having score between 0 to 1, then these patients should be considered for outpatient based treatment, and this patient should give antibiotic. And we should also consider the care provider is present or not, what is the social situation, what are the comorbid condition. If the patient have a higher number of comorbid condition, these patients should also be considered for hospital admission. If the score is 2, then hospital indication is required, hospital admission is required. Then we should provide supportive care, antibiotics, and relevant investigation. If the score is in between 3 to 5, this patient should must consider for hospital admission, and this patient should also be considered for need of intensive care unit support, and we should give the patient supportive care, relevant investigation, and treatment with antibiotics. This is CRB 65 rule, which is a practical scoring system meant for the OPD when the patient is coming in the OPD without any blood investigation. So this is basically CURB 65 scoring system minus urea. So if the patient is coming to us without any blood reports, we will calculate the CRB 65 system, in which confusion, respiratory rate more than 30, systolic blood pressure less than 90, age more than 65 is assigned a 1 point for each. If the patient is having 0 point, so there is a low risk of mortality and home care based treatment can be advised to the patient. If the patient having 1 to 2 point, then it has patient is required for a hospital assessment, and the patient is having 3 to 4 point, there is a high risk of mortality, so these kind of patients should be urgently hospitalized. Another scoring system is a smart cope scoring system, which reflect about the need of the vasopressor and intensive care support, respiratory intensive care support. As in smart cope, S stand for systolic blood pressure, M stand for multilobar X-ray involvement, A for albumin, R for respiratory rate 25 breath per minute or more, T for tachycardia, C for confusion, O oxygen saturation, P pH less than 7.35. So this scoring system has similar parameter for age less than 50 and age more than 50. And after calculating total sum for a patient, if the patient is having 0 to 2 score, the patient has low risk of needing intensive care for respiratory or vasopressor score. If the patient is having score more than 7, then patient have very high risk of requirement of intensive care and vasopressor support. Another scoring system is PS CURXO CURXO 80 scoring system, in which C stand for confusion, U stand for blood urea nitrogen, R stand of respiratory rate breath per minute, X for X-ray multilobar or bilateral involvement, O for oxygenation, PaO2 less than 54 or PaO2 FiO2 ratio less than 250, 80 stand for age of the patient. So in this system, the low risk patient with less than 10 point, medium risk patient 10 to 19 point, high risk group more than 20 point. So this is the comparison of the different scoring system. In this table we can see that pneumonia severity index has the highest sensitivity of the 94.7%, and CURB 65 system has the highest specificity 86.4%. When we need for ICU admission, for ICU admission there is a ATS, IDSA, American Thoracic Society, Infectious Disease Society of America criteria for ICU admission. They have major criteria and minor criteria. In major criteria, need of the invasive mechanical ventilation, patient is in septic shock with need of vasopressor. In minor criteria, confusion, disorientation, blood urea nitrogen more than 20 mg per dl, respiratory rate more than 30 breath per minute, hypotension requiring aggressive fluid resuscitation, PaO2 FiO2 ratio less than 250, multilobar infiltrate, white blood cell less than 4000 cell per millimeter cube, platelet count less than 1 lakh cells per millimeter cube, core body temperature less than 36 degrees Celsius. So if the patient come with any of the major criteria, irrespective of presence or absence of any minor criteria, if the patient is having any of the major criteria, then we have to directly we have to admit that patient for the ICU. We should refer that patient for the ICU care. And if the patient is not having any major criteria, but the patient having any of the 3 minor criteria, then we can also consider these patients for the intensive care unit support. After defining the case is a pneumonia, after the initial classification and risk stratification, now we have to find the probable etiology for the case, because the probable etiological agents are very important when we will decide the empirical initial therapy, which is the next question for this case. What are the etiological agents which are commonly found? Bacteria, virus, fungi and parasite. The most commonly identified pathogens are Streptococcus pneumoniae, Haemophilus influenzae, and atypical organisms like Chlamydia pneumonia, Mycoplasma pneumonia, and Legionella species. So etiological agents also depend on the age of the patient. As from birth to third week of the patient, Group B Streptococci, Listeria monocytogen, gram-negative bacilli, and cytomegalovirus are the more common causative agents. From age 3 weeks to 3 months, Streptococcus pneumoniae, viruses like respiratory syncytial virus, parainfluenza virus, Bordetella pertussis, Staphylococcus aureus, Chlamydia trachomatis are the most commonly encountered organisms. From 4 months to 4 years, Streptococcus pneumoniae, viruses like respiratory syncytial virus, parainfluenza viruses, influenza viruses, adenoviruses, rhinoviruses, metapneumoviruses. In the atypical organism, Mycoplasma pneumoniae in the older children, and group A Streptococci are the common bacteriological agent which can found in the age group 4 months to 4 years. From 5 years to 15 years, Streptococcus pneumoniae, Mycoplasma pneumoniae, and the Chlamydia pneumoniae are the most common organism. Now the community-acquired pneumonia in adults. In the outpatients with no modifying risk factor, Streptococcus pneumoniae, Mycoplasma pneumoniae, Chlamydia pneumoniae, Haemophilus influenza, respiratory viruses, miscellaneous organisms like Legionella species, Mycobacterium tuberculosis, and endemic fungi. Mycobacteria is specially mentioned, like it is not causing the community-acquired pneumonia, but it has to be always keep in mind, and we have to rule out the Mycobacterium tuberculosis, especially in our country like India, because it is a high tuberculosis prevalence zone. So we should always think whenever we are dealing with a case of pneumonia, we should always keep in mind, because although it is not causing the community-acquired pneumonia, but we should always keep in mind the Mycobacterium tuberculosis, because we have to rule out this disease. So what are the different modifying risk factors? Risk factors are like smoking, alcoholism, nutritional support, deficiency, and immunosuppressive conditions. So these are the modifiable risk factors which are present. The patient with modified risk factor, as we have discussed in the last slide, that if the modifying risk factors are present, then Streptococcus pneumoniae, including drug resistance form of Mycoplasma pneumoniae, Chlamydia pneumoniae, mixed infection with bacteria plus atypical pathogen or viruses, H. influenza, enteric gram-negative organism, respiratory viruses, miscellaneous, Moraxella catarrhalis, Legionella species, anaerobic, whether there is a chance risk of aspiration, if the patient is unconscious, patient having low mental IQ status, patient having dementia. So these kind of patient have or having any orofacial abnormalities. So these kind of patient have high risk of aspiration. So in these kind of patient, we should always consider anaerobic organism as a etiological cause for the pneumonia. As we already discussed the Mycobacterium tuberculosis, we should always keep in mind, and the endemic fungi. The fungal infection are most commonly seen in a patient with immunocompromised status, or the patient on a long-term steroid use, or the patient in uncontrolled diabetes, or patient on an immunosuppressive drug. So these kind of patient we should consider for the fungal infection also. What are the different non-bacterial pathogen causing community-acquired pneumonia? In non-bacterial pathogen, we have the viruses. Mainly we have viruses, influenza virus, adenoviruses, rhinoviruses, and recently we have seen an epidemic of COVID-19 virus, COVID-19. So these are the viruses which can also cause, and sometimes they remain undiagnosed also. So they can cause a community-acquired pneumonia with a superadded bacterial infection also there. So they can be misdiagnosed. So in the fungi, Aspergillus species, Candida species, Coccidomycosis. So as we discussed that these are mainly in the immunocompromised patient with HIV, patient with on immunosuppressive, patient on corticosteroid therapy. the patient with uncontrolled diabetes. So in these kind of patient, fungal infection should also be considered. So what are the different investigation to find out the etiological cause? So in the radiology part, we have the chest X-ray and the CT thorax. In the microbiology part, we have the gram stain, culture sensitivity, fungal stain, fungal culture. We can also have the viral PCR test, and we should never forget to do about the AFB staining, ZN staining for the Mycobacterium tuberculosis, because we are living in a high prevalence country for tuberculosis. There are antigen detection tests for and there are routine blood investigations. Now we see one by one. In the chest X-ray is a cornerstone of diagnosis, although we can diagnose the pneumonia without chest X-ray also. In chest X-ray, we can find an asymmetric increase in the lung opacification with air bronchogram, presence of Silhouette sign, an area of increased opacity bounded by a well-defined interface against adjacent aerated lung, such as along the fissure. If only an anterior posterior view is obtained, such as a portable examination, increased attenuation of cardiac shadow can also be a hint for a consolidation patch, which is not clearly visible in the X-ray, in the AP view. For radiograph with wide air space disease, more asymmetric multifocal distribution of the opacities. There are certain things we can also think of about the etiological, about the bacteria of the disease. In the case of aspiration pneumonitis, they can affect a specific zones in the lower part. In the right side is more commonly affected. In case of Klebsiella pneumonia, we can have a bulging fissure sign. So it is a hint. It is not 100%, but it is a hint that most probably bacterial pathogen is Klebsiella pneumonia if we are getting bulging fissure sign in the chest X-ray. So what are the recommendations? These are recommendations basically from the Indian guidelines and American Thoracic Society IDSA guidelines. So when we should do a chest X-ray, whenever is feasible, a chest X-ray should be obtained in all patients suspected of having community-acquired pneumonia. In absence of availability of chest X-ray, patient should start treatment on the basis of clinical suspicion without any delay. And the second question is, when chest X-ray should be repeated? For after how many days? So answer is, if the patient is improving and patient having decreased sign and symptom, that there is no need to repeat the chest X-ray. But if our patient is not improving, or there is worsening of symptom, or there is a persistence of symptom, then we should repeat the chest X-ray for these kind of patient. Otherwise, there is no need to repeat. If the patient is improved clinically or symptomatically, so there is no need to repeat the chest X-ray. Now come to the CT thorax. In CT scan, in case of pneumonia, we can find the air space consolidation, ground glass attenuation, and thickening of the bronchovascular bundle. And we can also find pleural effusion in some cases. In this X-ray, we can find that this is the air bronchogram. We can see there is a opacification, air space consolidation in this patient. We can thickening of the bronchovascular bundle. In this X-ray, we can also see this in this X-ray. So these are the things we can find in the CT thorax. So what is the recommendation for CT thorax? Whether CT thorax should do it routinely in all patients? But no, CT thorax should not be performed routinely in patients with community-acquired pneumonia. CT thorax should be performed in those patients with non-resolving pneumonia and for the assessment of other for the assessment of complication of community-acquired pneumonia. Now come to the sputum gram stain and culture. The yield of sputum culture varies from 34 to 86%. So why this is so much variation? Because of the quality of the sputum sample. So what is a good quality sputum? We should only a good quality sputum sample with a predominant pus cell with a proportionately less epithelial cells and bacterial pathogen can observe in approximately only 15% of the cases. So what is good sputum sample? It should be predominantly pus cell with less number of epithelial cell and bacteria should be observed. So how we should accept the sample for the um, culture? So before accepting the sample for the culture, we should examine at least 40 field of the sputum smear under low power. If the number of epithelial cell is in the representative field, if epithelial cell are more than 10 per low power field, the sample should be rejected for the culture. If the number of pus cell is 10 times of the number of the epithelial cell with 3 plus or 4 plus of a single morphotype of bacteria, the sample should be accepted. So if the epithelial cell is more than 10, it is not a good sample. So we should reject. If the pus cell is more than 10 times of the epithelial cell and we are showing bacteria 3 plus or 4 plus, then only we should accept the culture, sample for culture. So what are the recommendations for doing the sputum gram stain and culture? An initial sputum gram stain and culture or an invasive respiratory sample as appropriate like a bronchoalveolar lavage should be obtained in all hospitalized patients with community acquired pneumonia. Sputum quality should be ensured for interpreting gram stain results. Sputum for acid-fast bacilli should be obtained as per anti-EP guidelines for non-responders. Now come to the blood culture. What is the role of blood culture? Blood culture have low sensitivity but high specificity in identifying the microbiological etiology. It varies from 5% to 35%. Blood culture should be obtained in all hospitalized patients with community-acquired pneumonia. Blood cultures are not required in routine outpatient management of community-acquired pneumonia. What about the antigen detection test for the pneumococcal antigen detection test and pneumococcal PCR? So considering the cost and the availability of the test, it may not have a favorable cost to benefit ratio. If available, it should be offered to only those patients who are not resolving with the present treatment, or if there is any diagnostic dilemma, whether it is an infective etiology or some other etiology is there, or in the infective etiology, whether it is a bacterial or other etiology is there, then only we should offer if it is available. And Legionella antigen detection test, Legionella urinary antigen test is desirable in patient with severe, only in the severe community acquired pneumonia patients. Now come to the general investigation, routine investigation. The 4 patients managed in outpatient setting, no investigation are routinely required apart from the chest X-ray. Pulse oximetry is desirable in outpatients to all the patients. Pulse oximetric saturation, if available, should be obtained as early as possible in admitted patient. Arterial blood gas analysis should be performed in those patients with an oxygen saturation of less than 90%. And in those patients with chronic lung disease like COPD, interstitial lung disease and asthma, as these patients might have the respiratory failure either type 1 or type 2, and they may have hypercapnia also. The blood glucose examination, urea and electrolyte should be obtained in all hospitalized patients with community acquired pneumonia. Full blood count and liver function tests are also helpful in the management of patients with the community acquired pneumonia, because the total blood count and in the liver function test, the OTPT, SGOTPT can reflect about the oxygenation decongestive condition of the liver, and also we have the albumin as a prognostic marker in the scoring system like SmartCope, etc. So very important question, what is the role of biomarker? we have more commonly used the procalcitonin and the C-reactive protein. These two biomarkers are most commonly used. But most of the guidelines says that these biomarkers do not have any role in the diagnosis part of the pneumonia. They have limited role in a patient with community-acquired pneumonia, as in this graph on the left side we can see there is a diagnostic sensitivity of the C-reactive protein with the chest X-ray. If the CRP and chest X-ray both has been done, so this graph showing the diagnostic sensitivity of the CRP. On the right hand side, this graph shows the sensitivity of C-reactive protein without chest X-ray. So we can see that as we compare with this graph, the diagnostic sensitivity remarkably decrease without chest X-ray for diagnosing community-acquired pneumonia. So CRP is not a good test for diagnosis. Same about procalcitonin. So procalcitonin, high procalcitonin value correlates with the bacterial infection. Sensitivity of procalcitonin to detect bacterial infection varies in between 38 to 91%. So even though procalcitonin levels are not available, we should not delay. If it is a clinico-radiologically confirmed case of community-acquired pneumonia, we should not delay our treatment and for the procalcitonin level, and we should start the treatment as early as possible. Procalcitonin level can be used as more used as a prognostic marker, so rather than the diagnostic marker. And there is no threshold value for withholding antibiotic with the procalcitonin. So there is no specific value. After reaching this procalcitonin level value, we will stop the antibiotic therapy. So this is the role of the biomarkers in case of the community-acquired pneumonia. Now we have answered our 4 questions about the pneumonia. We have defined the pneumonia, we have done the clinical classification, risk stratification, and we have how to find the etiological cause to the pneumonia. Now come to the how we should, when the patient come to us, how we should start the empirical initial therapy. So antibiotics are the mainstay of treatment in the case of bacterial etiology. So which are the antibiotics useful for empirical treatment in various settings? So initial empiric antibiotic treatment is based on the number of factors, like the most likely pathogens, for which we can refer the age group of the patient, risk factor for the patient, comorbid condition for the patient, and what are the different, which is the region, and is there any endemic pathogen belongs to that region. So we should also we should consider all these things before deciding the antibiotics. Knowledge of local susceptibility patterns. So there is a local susceptibility pattern of the different bacterial pathogens. We should always keep in mind, and we should have record of these local susceptibility pattern, and we should always keep in mind before starting the empirical antibiotics. What is the pharmacokinetics of the drug and what is the pharmacodynamic of the drug? We should always keep in mind. So whether it is a time dependent or whether it is a dose dependent. So if we are knowing this, then we can give the appropriate dose to the patient. And we should also know what is the route of the clearance of the drug, whether drug is nephrotoxic or hepatotoxic. If the patient is having CKD as a comorbid condition, then we have to modify the dose of the nephrotoxic drug as per the GFR of the patient. So these all things we should keep in the mind. What is the compliance, safety, and the cost of the drug? The cost of the drug is very important. So we should also keep in the mind, if the same effective drug at the less price is available, then we should use that drug. Last but not least, the recently administrative drug. We should always take a detailed history about the recently administrative drug, because there are chances of having drug resistance to that drug which is recently administered. Also we can guess about the response to that particular drug. If that drug already patient have taken 5-7 days and patient is not having any response, then we have to rethink about the selection of the drug and we have to change the drug. Now, whether is there any need to cover the atypical organism? Yes. Atypical organism, especially Mycoplasma, Chlamydia, and Legionella, also contribute significantly to the incidence of community-acquired pneumonia. Combination therapy in patients with severe pneumonia has been shown to decrease mortality. So, coverage, giving atypical coverage to the patient has shown that there is a decrease in the mortality of the patient. The most important thing is antibiotics should be started as soon as possible. If the patient, we receive patient in the emergency department, it should be started even in the emergency department so that there is no wastage of time, and we should not wait for the investigation reports to become. We should send all the culture and thing, and then immediately we should administer the antibiotic therapy to the patient. Now, what is the treatment for the outpatient patient, the patient who are treating at the home-based care? And therapy should be targeted toward the coverage of the most common organism, like in adult Streptococcus pneumonia. Outpatient should be stratified as those with or without comorbidities. So we should always look for the comorbid condition in the patient, and the patient having without any comorbid condition and no use of antibiotic in the past 3 months. So these patients can be treated with the single antibiotic therapy only. So the recommended antibiotics are oral macrolide like azithromycin, clarithromycin, or beta-lactams, amoxicillin, 500 to 100 milligram thrice daily for outpatient without comorbidities. What are the different comorbid medical conditions to which we have to look for the, like chronic heart disease, chronic liver disease, chronic kidney disease, diabetes mellitus, alcoholism, malignancy, use of antimicrobial within the previous 3 months, severe community-acquired pneumonia with or without comorbidity. So in these kind of patients, we should never use a single antibiotic therapy, whether we should go for combination therapy. So in combination therapy, in outpatient, we should have beta-lactam plus macrolide. If the patient is able to take orally, then only we advise this patient to outpatient basis. So beta-lactam plus macrolide is a drug of choice for these kind of patients. Fluoroquinolone should not be used for empirical treatment, as we are living in a high prevalence of the tuberculosis area. So we should, as we know that fluoroquinolone like levofloxacin, moxifloxacin are very important drug for the treatment of the drug resistance tuberculosis in case of MDR and MDR patients. So we should not use in the empirical treatment. So antibiotics should be given in appropriate dose to prevent the emergence of resistance and for the appropriate duration. Inpatient, non-ICU, for the treatment of inpatient non-ICU patient, the recommended regimen is a combination of beta-lactam plus macrolide, and a preferred beta-lactam include cephalosporin, cefotaxime, ceftriaxone, and amoxicillin clavonic acid. In the uncommon scenario, if the hypersensitivity to beta-lactam, then levofloxacin can be used if the tuberculosis is not a diagnosis of concern. Patient should also undergo sputum testing for acid-fast bacilli to rule out the tuberculosis. Route of administration, oral or parenteral, should be decided based on the clinical condition of the patient and the judgment of the treating physician, and regarding the tolerance efficacy of the chosen antibiotic therapy. For the inpatient of the ICU patient, for patient in the ICU, the recommended regimen is beta-lactam, cefotaxime, ceftriaxone, or amoxicillin clavulanic plus macrolide for patient without risk factor for Pseudomonas aeruginosa. If the patient having risk factor for Pseudomonas aeruginosa, then we should also add the anti-pseudomonial antibiotic with the anti-pneumococcal antibiotic. Example like anti-pseudomonial like cefepime, ceftazidime, cefoperazone, piperacillin tazobactam, imipenem, meropenem should be added if there is a Pseudomonas is a risk factor for Pseudomonas aeruginosa as a causative organism. And combination therapy may be considered with addition of aminoglycoside, anti-pseudomonial fluoroquinolone like ciprofloxacin. Fluoroquinolone may be used if tuberculosis, if not a diagnosis of is not a diagnosis of consideration. Patient should also undergo sputum testing for acid-fast bacilli to rule out the tuberculosis. And what is the optimum duration of treatment? Most of the patients respond within 3 to 7 days. Longer duration are not required routinely. Also, short course treatment less than 7 days has been found to be as effective as longer duration of treatment. So 3 to 7 days is sufficient. If based on the clinical judgment, if the patient is if the treating physician think that patient required longer duration, that it can be extended, but usually in the most of the patient less than 7 days course has to be found effective. And when to switch oral from IV? It is safe after clinical improvement in moderate to severe community acquired pneumonia. Patient can be considered for discharge if they start accepting orally. Patient become afebrile. Patient become hemodynamically stable for a period of at least 48 hours. Outpatient should be treated for 5 days and inpatient for 7 days. Antibiotic may be continued beyond this period in the patient with bacteremic pneumococcal pneumonia, Staph aureus pneumonia, and community acquired pneumonia caused by Legionella pneumoniae and non-lactose fermenting gram-negative bacilli. Antibiotics may also be continued beyond the specified period in those with meningitis or endocarditis, complicating pneumonia, infections with enteric gram-negative bacilli, lung abscess, empyema, and if the initial therapy was not active against identified pathogen. What the last statement means, if we start the empirical treatment, later we got the culture report, and the culture report state that they have the different pathogen which is not sensitive to the empirically used antibiotic, then we can also increase the duration with the sensitive antibiotic in the reports. Now, what is the role of oseltamivir? Oseltamivir should be given to all suspect, irrespective of the duration of illness before diagnosis in person who test positive on viral PCR. So oseltamivir should be given in all patients who test positive on viral PCR. Best outcome of the treatment is started within 48 hours, but benefit is observed even if the therapy is started later. Now, what are the different clues for the multi-drug resistance pneumococci? If the patient is having age more than 65, prior 3 to 6 month beta-lactam, fluoroquinolone or macrolide therapy, patient is having alcoholism, patient have medical comorbidities, patient is on immunosuppressive illness or therapy, patient is exposure to a child in a daycare center. So patient is a child, and if patient is has a stay in a daycare center, then these are the various risk factors for having the multi-drug resistant pneumococci. Now come to the clues to the MRSA. MRSA, methicillin resistant Staphylococcus aureus. Colonization, past infection and hospitalization with IV antibiotics within the 3 months. Gram stain, gram positive cocci on good quality sputum. Recent antibiotic therapy of any kind. recent influenza-like illness, necrotizing or cavitatory pneumonia, empyema, need for intubation, septic shock, end-stage kidney disease, contact sport, IV drug use, crowd living condition, prisoners. So these are the various clues for the methicillin-resistant Staphylococcus aureus. Now, very important question: is there any role of steroid in a patient with community-acquired pneumonia? Usually, we do not use steroids in a patient of community-acquired pneumonia. Only we use steroid in case community-acquired pneumonia with septic shock refractory to fluid and vasopressor therapy. To increase the glucocorticoid and mineralocorticoid activity, we use steroids to maintain the hemodynamics of the patient. Or if the patient having FiO2 requirement more than 50% or more of the metabolic acidosis with pH less than 7.3, if the patient has lactate level more than 4 millimole per liter, if the patient have CRP more than 150 milligram per liter. So these are the different indications in which we can use the steroids. What will we do when nothing is working? We have tried everything, we have tried all the therapies, but patient outcome is not become very good. So then we again start from the beginning. Start from the chief complaint history. We have to look for the travel history of the patient. We have to look for the dietary history of the patient. We have to look for the occupational history of the patient. So whether the patient travel to any zone which is having specific organism endemic to that particular zone, patient is having any dairy industry, whether the patient belong to dairy industry or any other poultry farm, anything. So these kind of occupational history we should have to gather if the patient is not improving. So in wheel flex disease, these are the some things like Rocky Mountain spotted fever, rickettsial pox, epidemic typhus, endemic typhus, scrub typhus. So these are the uncommon thing. If the patient is not improving, we should also consider these kind of etiology and we have to treat accordingly. What is clinical stability criteria? When we call that patient is stable, if the temperature is less than 37.8 degrees Celsius, heart rate less than 100 beats per minute, respiratory rate less than 24 breaths per minute, systolic blood pressure more than or equal to 90 mmHg, arterial oxygen saturation more than equal to 90%, or PO2 more than equal to 60 mmHg on room air, ability to maintain oral intake, or normal mental status. Patient is recognizing all his attendant. Expected, and these in the next part, what are the different expected time for the resolution of symptom? If the patient attendant will ask in how many days I am going to resolve my fever. If we have on the correct path, the temperature will be resolved approximately 3 days, clinical stability in the 4 days, cough in the 8 days, crackle in 3 days, persistent of pneumonia related symptom 2 weeks to long term, and chest X-ray resolution may take 4 to 8 weeks. So this is very important part. So chest X-ray resolution may take more longer duration as compared to the clinical improvement. So another thing, if the patient is requiring oxygen support, so in case of pneumonia, due to the surge of inflammatory cytokines, there is a destruction of squamous cells, epithelium. So there is a regeneration of, there is a replacement of squamous cell from the cuboidal cell. So there will be take some time for the metaplasia from cuboidal cell to squamous cell. So patient may feel dyspnea on exertion, or patient may need oxygen requirement for a longer duration, as approximately 15 to 20 days is required for this metaplasia. So patient can be maybe dyspneic on exertion, or patient may require oxygen support for longer duration in case of severe community acquired pneumonia. So what is role of immunization? Most guidelines recommend immunization with pneumococcal and seasonal infection vaccine for specific group. So these are the specific group for pneumococcal disease, vaccination for pneumococcal disease, chronic cardiovascular, chronic pulmonary, chronic renal and chronic liver disease, diabetes mellitus, cerebrospinal fluid leak, alcoholism, asplenia, immunocompromising condition or patient on immunosuppressive drugs. And influenza vaccination is recommended in case of chronic cardiovascular, chronic pulmonary disease including asthma, chronic metabolic disease including diabetes mellitus, renal dysfunction, hemoglobinopathy, immunocompromising condition, the patient on immunocompromising medications, and the compromised respiratory function or compromised respiratory function or increased risk of aspiration. So what are the different complications of the pneumonia? These are ARDS, acute respiratory distress syndrome, sepsis, patient can go to septic shock, pyothorax. In case of complicated pneumonia, if the patient is having effusion, parapneumonic effusion, and the respiratory failure. Thank you.